Hi, I'm Tony Sreih. I'm assistant professor of medicine at the University of Pennsylvania. I actually started a couple of weeks ago. I came from Chicago, where I used to work at Rush University Medical Center. I came here to work on the vasculitis research, a clinical research consortium. So I can tell you about my background. I'm Lebanese in origin. I did my residency at the Hospital of St. Raphael, which is now actually Yale New Haven Hospital. And then I practiced medicine for about, I would say, 5 years. And then I decided to do a rheumatology fellowship at Yale School of Medicine. As a medical student, I actually I didn't like rheumatology at all. You know, for medical students, rheumatology is actually this unusual, not well understood specialty. It's one esoteric specialty. And most of the difficult questions in rheumatology, most of the difficult questions in medicine were actually rheumatology questions. So nobody, as medical students, nobody actually liked rheumatology at all. But then as I started practicing medicine, I realized that some of the most difficult cases and when nobody knew anything actually were rheumatology rheumatology patients. And then this is what started to draw me closer to rheumatology, because I wanted to help the people who didn't have answers. So rheumatology actually was sort of like a Sherlock Holmes of medicine, and I sort of wanted to be the Sherlock Holmes of medicine. What drew me to vasculitis is actually vasculitis is one of the most difficult diseases in rheumatology. Most of the rheumatologists actually prefer not to deal with it because it can present in any shapes and forms. It can affect any organ in the body. So people actually had to have a good understanding of different organs and different systems in the body to be able to take care of vasculitis. So in a way, I became sort of like the Sherlock Holmes of rheumatology. And now I look back and I can't see myself anything else other than a rheumatologist. I just love it. It's an amazing specialty. You can make a huge difference in patients' lives, and you can actually see how patients transfer from being totally disabled to living amazing lives. Like I said, when I was a medical student, actually, most of the treatments were, the only treatment that we had and the only way to diagnose was to do a physical test and then classify into criteria and determine if someone has a specific disease. But then, with time, rheumatology has evolved. Now we understand the diseases better. We can look at the diseases in a totally different way. In a way, we can diagnose better. And we have a lot more to offer to patients than what we used to do before. Before it used to be prednisone and possibly gold. And the gold would go up and down in price based on the stock market. But now we have a lot more to offer, and then we can customize based on the severity and the type of vasculitis. So patients actually can enjoy the new research and the new findings because we have a lot more to offer to them these days than before. Because I do mostly Hispanics and then minorities. Actually, when I was practicing in Chicago, and because I speak Spanish, a little bit of Spanish, I was being referred a lot of Spanish and Latino speaking patients. And then You see, in Chicago, the ethnic background in Chicago is actually 1/3 Caucasians, 1/3 African Americans, and 1/3 Hispanics. And that sort of reflect what's going on in the major cities in the United States. And actually, it's predicted by 2050 that the biggest ethnic group is going to be Latino or Hispanics group. So as I was practicing in Chicago, I was seeing a lot of Spanish-speaking patients. And it turns out, and also I was seeing African-American patients, and I was able to compare between patients from different backgrounds and different ethnic backgrounds. And I actually started noticing that manifestations and disease is totally different between the 3 different ethnic groups. Actually, we've observed that Hispanic patients tended to have a much more severe disease at presentation. So they presented with more kidney disease, kidney failure, needed more dialysis, had more bleeding in the lungs than actually their counterparts or the Caucasians who had similar disease and lived in the same geographical area. And that actually pushed me to start studying this disease in minorities. Plus minorities, unfortunately, they don't get enough attention because they're minorities. And that's what drew me to this particular group. So I started scientifically looking at the differences between Hispanics and Caucasians. And it turns out actually that Hispanics present with a much more severe disease as compared to their Caucasians, to their controls. Which is really important because it gives us, usually those differences are actually attributed to differences in socioeconomic status or differences in education or differences in healthcare disparities. But when we looked at our study, there were no differences in healthcare disparities. There was no delay in diagnosis between the 2 groups. And then there's no difference in terms of healthcare access, which led us to believe actually it's due to maybe genetic background or maybe different education. People would think, maybe minorities, they don't have insurance, they have different education, maybe potentially wait until the disease is more severe to present. But actually, we didn't see this in our study. We saw that they present from the get-go with a more systemic, more severe disease than their Caucasian counterparts. That led us to actually now think to not do the study not only in Chicago, but also in all the cities in the United States. And hopefully we can also compare the population here in the United States, the Latino population, to the Latino population back in their home countries. Because if there's difference in their disease and disease manifestation and severity, that gives us an idea about the possibility of the environment playing a major role in that, in the disease itself. So not only genetics, but also environment as a possible cause of the disease or a contributor to the disease. So that's why it is important to study diseases in minorities. So this concept actually is not a totally new concept. This concept exists in other diseases. We know, for instance, in lupus, Hispanic patients have a much worse disease, or African American patients have a much worse disease and more severe disease than Caucasians. So this is, I'm not bringing a totally new concept, but I'm bringing a totally new concept to vasculitis, which is like lupus, vasculitis can affect minorities and can cause a much more severe disease. So maybe if we know that, if we're aware of that, we can catch it earlier and make a difference in their lives. There's maybe a misunderstanding in rheumatology thinking that vasculitis is a disease of Caucasians. I'm not so sure this is completely true because first, I was seeing vasculitis in a lot of Hispanics back in Chicago. And this is maybe a serious misconception because if someone who's Hispanic or African American present with symptoms suggestive of vasculitis, if someone thinks that because they're Hispanics, because they're African Americans, they can't have vasculitis or they have less likely to have vasculitis, then you don't think about vasculitis. Then potentially that can delay the diagnosis and they won't be diagnosed in a timely fashion. So this is important to actually notice and pay attention to because it can make a difference in patients' lives and expediting the process of diagnosis. In any disease, we think, not just in vasculitis, we always think that there's some sort of an interaction between the environment and the genetics. You have to have some genetic predisposition to actually develop a disease. But we know this is not the whole true story because if genetics are only the cause of the disease, then you'd expect that true twins or identical twins would develop the disease at the same time, the same way. And that's not true. We haven't seen this. So we know that there's some sort of environmental exposure. Now we know actually in different diseases or in our disease in rheumatology, some exposure to some, for instance, bacteria. I would say we know that exposure to Streptococcus tonsillitis will cause arthritis down the road. So we know that some sort of an exposure can potentially trigger an autoimmune disease. So in vasculitis in particular, I think, and this is not a totally new concept, patients or researchers have looked at silica as a possible exposure. Because silica, what it does once it goes in, it causes what we call a granuloma, which is actually a collection of inflammatory cells around this foreign body. And this is what we actually see in GPA and granulomatosis with polyangiitis, Wegener's. We see those granulomas around some sort of an exposure or a foreign body that we're still not sure. And also it turns out that we've had clusters of GPA patients in certain zip codes, which is really amazing because if clusters do occur, then it tells you that there's some sort of an exposure to those patients. So I believe now, I think there's an ongoing study looking at the disease at vasculitis based on your zip code, which tells us about possible potential exposures. I did a little interesting project. I looked at Google actually. And then what's interesting about Google, Google will let you, if you put, for instance, the term vasculitis or granulomatosis with vasculitis, it tells you, if you trend it on Google, it tells you the years where the interest were most, but also it tells you which areas in the world were mostly interested in granulomatosis with polyangiitis or vasculitis. So it turns out when I did this, it turns out that actually there's some areas in the world that were more interested in granulomatosis with polyangiitis than other areas in the world. And that led me to believe, aside from saying that you have a university here who's doing research and then looking and then using Google to look at the disease itself or manifestation, potentially there are actually patients maybe searching for GPA and thereby creating those hot spots in the world with interest in GPA. But also it can tell us if there are hot spots in those different countries, maybe there are hot spots because of some sort of exposure. When I looked at it, it turns out that there's a city, a small town in England, a very small town in England, that there were 100% interest in GPA from that town. And I thought maybe, you know, those patients are interested because they're coming down with symptoms that are similar to GPA. And when I looked at what that town was known for, it turns out that it's known for making steel. So I'm starting to wonder if there's some sort of an exposure, if it happens to people who have some sort of a genetic background or some sort of an autoimmunity going on, then exposure to certain material will lead to the manifestation of the disease. That's amazing because technology these days allows us to do a lot of those stuff that we didn't have to do. I did this, you know, on Google. I did it in one afternoon. It took me an hour to do it, and that was it. Before, it used to have people travel to those, you know, to those hot spots and fill out surveys and do all those stuff. It took me actually 10 minutes. All I had to do was type GPA and then see where the hot spots were in the world and how it changed over time. And actually, when I did that, I wanted to see if those interests during the years matched the scientific reports of epidemics of GPA, because we know GPA varies with seasons and years. We've had 2 sort of epidemics during the year, and that tells you about possible, you know, environmental exposure. It turns out that the Google interest actually matched those years at the same time, which led me to believe I can potentially trust Google in a way that raising the interest during those years can potentially represent the actual occurrence of the disease itself. This project is really young. It's at the beginning. But it's amazing because it gives us 2 ideas. Because first, it tells us how technology and the internet has changed our ways of looking at things. And also it tells us, it helps us broaden our thinking and then looking for all the possibilities. Maybe if we know what type of exposure, we can prevent it or cure the disease by actually avoiding those exposures. Like when you get exposed to bacteria and then you start having a disease, you get antibiotics or you avoid this bacteria and the disease goes away. Hopefully one day it will turn out to be the same for GPA or MPA or any type of vasculitis in that matter. Definitely, as physicians, we need you. Vasculitis is a rare disease. If we don't have patients participating in the research, then it's impossible to conduct research. We have to come together as patients because we need you and we need enough numbers, otherwise we won't be able to advance this field. Therefore, by doing this, you're not just helping yourself, but you're helping thousands and thousands of other patients who will benefit from this research and in their turn will actually participate in those research. Imagine we didn't have research. We would be still using prednisone and nothing else, or maybe Cytoxan. But because of you, because of your participation, we're able to offer alternatives other than Cytoxan, maybe less toxic. Now we have rituximab for MPA, GPA. So research is really important, and I can't tell you enough how important it is to be able to advance knowledge and help our patients and find a cure, hopefully.